Good afternoon and welcome back. I think it's time to begin our third program. We're going to finish with a flourish. We have 4 exciting speakers to finish out the day. I would once again thank you all for attending and participating on behalf of my fellow directors, Dr. Champion and Dr. Molly. Also want to remind you that this will consist of 4 sessions, 15 minutes each, up to 5 minutes of questions. For virtual participants, use the Zoom question and answer box. For anyone here, please raise your hand. And one last reminder about door prizes. We will do the drawings after Dr. Champion's talk. And I think Lauren has all of the passports. If you have a passport you would like Lauren to have, then please give it to Lauren to put in the blue bucket. We're going to begin with session 3A, follicular lymphoma updates, by Dr. Rebecca Champion, PharmD, BCOP. Dr. Champion has been at Norton Healthcare for over a score of years. In that time, she has developed the role of clinical pharmacy specialist and now serves as the clinical pharmacy manager for the Norton Cancer Institute. She is a highly sought-after speaker and educator. Most recently, Dr. Champion was an invited speaker at the annual national meeting of the Hematology Oncology Pharmacy Association. And without further ado, Dr. Champion.
Thank you so much, Dr. Stevens. Today we will be talking about new therapies for patients with follicular lymphoma. These are my disclosures. Of note, we will be talking about investigational medications as well as off-label use of medications. Our learning objectives: we will review emerging therapies in the treatment of patients with follicular lymphoma and evaluate the toxicity profile of new therapies for patients with FL. Follicular lymphoma is an indolent or slow-growing non-Hodgkin lymphoma. It's estimated that approximately 15,000 cases will be diagnosed annually, making this the second most common lymphoma seen in practice. As we think about our treatment options for patients, it really depends on the extent and stage of a patient's disease, as well as the patient's age and comorbidities. For some patients, that watch and wait that Dr. Flynn talked about earlier may be appropriate. Some patients may receive CD20 monoclonal antibodies. This may be in combination with cytotoxic chemotherapy. In that relapse refractory space, we can also include immunomodulatory agents as well as small molecule inhibitors. Even CAR T is a therapy option available for patients with follicular lymphoma. But what we know is that even in 2023, follicular lymphoma remains an incurable disease. Ultimately, these patients will relapse, and new therapies are still needed for patients. We'll start talking about bispecific antibodies for patients with follicular lymphoma. And we'll start with mosunetuzumab. Mosunetuzumab is an IgG1 bispecific antibody. This bispecific antibody targets CD3 expressed on T cells and CD20 expressed on B cells. This interaction causes T cell activation, a release of these pro-inflammatory cytokines, and ultimately lysis of the target B cells. FDA approval was based on a phase 2 clinical trial that looked at patients with grade 1 to 3A follicular lymphoma. These patients had to have an ECOG performance status of 0 to 1, and they had to be relapsed or refractory after 2 or more lines of prior therapy, including an anti-CD20 monoclonal antibody and an alkylating agent. The primary outcome of the study was complete response rate. Secondary outcomes included objective response, duration of response, progression-free survival, and overall survival. I want to take just a minute and talk about the dosing of mosunetuzumab. It's given in a step-up dosing fashion. On cycle 1, day 1, patients will receive 1 milligram given as an IV infusion. And if tolerated, patients will increase to 2 milligrams on day 8. They will then increase to 60 milligrams on cycle 1, day 15. On cycle 2, they will again receive that 60 milligram dose. And then starting with cycle 3, patients will be maintained on 30 milligrams given as an IV infusion every 21 days. Pre-medication was required for cycles 1 and 2, but was optional starting with cycle 3. Disease assessment was obtained after 8 cycles. For patients who achieved a CR after 8 cycles, patients would stop therapy. If patients achieved either a partial response or if they had stable disease, they could go on to continue up to 17 cycles of mosunetuzumab. It's also important to note that there was no mandatory hospitalization for treatment administration. A total of 90 patients were enrolled in the study. The median number of lines were 3. The majority of these patients were considered refractory to their previous line of therapy. That means that they had relapsed on or within 6 months of their last cycle of therapy. We see an objective response rate of about 80% in those patients, 60% of those patients achieving a complete response. We can also see these responses quickly. Time to first response was approximately 1.4 months. The time to first complete response was 3 months. And what we see is that these responses were durable. The duration of response in those complete responders was 22.8 months. Progression-free survival is about 18 months, and overall survival has not yet been reached. Looking at the safety of mosunetuzumab, the majority of the adverse events seen with this agent was primarily myelosuppression. You can see lymphopenia and neutropenia were both seen in the clinical trial. About 50 to 60 patients did receive growth factor support per MD discretion. The other adverse events seen in this clinical trial were mainly grade 1 or 2 and included fatigue, pyrexia, edema, rash, and musculoskeletal pain. You've heard a lot about CRS and neurotoxicity. As we talk about cellular therapy, including CAR T therapy that we've discussed, as well as these bispecific engagers, such as mosunetuzumab, it's important that we understand exactly what's going on with these patients. Remember that we are engaging T cells to attack those cancer cells. But when we do that and we release those pro-inflammatory cytokines, we have a flood of IL-2, IL-6, interferon alpha, and tumor necrosis factor, just to name a few. And when we have that, we see this cytokine storm, what we call cytokine release syndrome. How does that manifest in our patients? We can oftentimes see hemodynamic instability. These patients may experience tachycardia, hypotension, even capillary leak syndrome. We can see organ dysfunction in these patients. We can also see neurotoxicity if we can see that cytokine response cross the blood-brain barrier. We can see delirium, expressive aphasia, seizures, cerebral edema, even intracranial hemorrhage in these patients. So how do we manage them? Well, remember that IL-6 is one of the cytokines that's released. We can use anti-IL-6 therapy such as tocilizumab. Toci will block that downstream signaling pathway that's implicated in CRS. We can also use corticosteroids. Corticosteroids do a great job of helping to decrease that immune response. We can use that both in CRS, or that cytokine release syndrome, but we can also use that when we see patients with neurotoxicity because of its ability to penetrate that blood-brain barrier. So when we look specifically at the cellular toxicities that we see with mosunetuzumab, you can see that the majority of CRS was grade 1 or 2. 26% of patients experienced grade 1 CRS, about 17% of patients experienced grade 2 CRS. When we look at the CRS by cycle, you can see that the majority of that CRS was seen at cycle 1, day 15, so that first 60 milligram dose that those patients receive. In looking at the median onset, it's about 5 hours after that first dose. It's about 27 hours after that first 60 milligram dose. Symptoms included fever, chills, hypotension, tachycardia, and hypoxia, and it's also important to note that all symptoms resolved. When looking at neurotoxicity, about 40% of patients experienced neurotoxicity across all grades. You can see that most of that was grade 1 or 2, with only 3% of patients experiencing grade 3 or higher neurotoxicity. The most common symptom that we see is headache. Patients may also experience peripheral neuropathy, dizziness, mental status changes. The onset and duration have not been reported from that study. So based on that phase 2 clinical trial, mosunetuzumab was granted accelerated approval in December of last year for the treatment of patients with relapsed or refractory follicular lymphoma after at least 2 lines of prior therapy. Mosunetuzumab has also been incorporated into the NCCN guidelines as an option for patients who are appropriate for T-cell mediated therapy. In looking at our options for those patients, you can see that mosunetuzumab provides us the one option that does not require leukapheresis, lymphodepleting chemotherapy, or a delay in the manufacturing process of that CAR T. It's also important to note that there's no REMS program that's associated with mosunetuzumab, and that hospitalization is not required for initiation of therapy. So as I mentioned, we're all very excited that we have our first IV bispecific antibody that's available for patients with B-cell lymphomas with mosunetuzumab. But there are several that are coming down the pipeline. Now, these vary different based on their structure, based on their binding capacity with CD20. They vary based on their route of administration, even their dosing and administration. And we're going to talk about just a couple of these. We'll start with odronextamab. Odronextamab is another IV bispecific antibody that targets CD3 expressed on T cells and CD20 expressed on B cells. Phase 2 data from the ELM-2 study was presented at ASH last year, and I'm very proud to say that Norton Cancer Institute participated in this study, also known as LYM 1935. You can see that patients had relapsed or refractory follicular lymphoma after at least 2 lines of prior therapy. The primary endpoint of the study is overall response rate, with secondary endpoints including complete response as well as duration of response. I put the dosing in here as well because I think you're going to start to see a pattern as we start talking about these bispecific antibodies. You're going to see that most of them are going to start with this low dose and then escalate to help mitigate those cellular toxicities that we talked about, that CRS and neurotoxicity. So with odronextamab, patients start at 0.7 milligrams, and that dose is split over 2 days. And if tolerated the following week, patients would increase to 4 milligrams. They would go up to 20, and then finally get up to 80 milligrams given as an IV infusion weekly. Patients were required to start this medication in the hospital. After 4 cycles of odronextamab, patients would go on to receive odronextamab at a dose of 160 milligrams, given as an IV infusion every 2 weeks, and this was continued until disease progression or unacceptable toxicity. A total of 131 patients were enrolled in the ELM-2 study. The median number of prior lines of therapy was 3. 70% of patients were refractory to their last therapy. And looking at the efficacy data, you can see an overall response rate of about 80%, with about 75% of patients achieving a complete response. We can also see that these responses are durable. The median duration of response was 18.2 months. The median progression-free survival, 20.2 months. And looking at the safety data, you can see cytokine release syndrome happened in about half of the patients. Patients also experienced pyrexia as well as anemia. Infusion-related reactions were seen in about 1/3 of patients. It's also interesting to note that there were no reports of neurotoxicity, or what we call ICANS. Looking at epcoritamab is another option for our patients that are potentially they could receive. This is our first subcutaneous bispecific antibody that targets CD3 and CD20. Epcoritamab has been studied both as a single agent as well as in combination with other therapies available. Data presented at ASH last year looked at the EPCOR FL1 study, which was epcoritamab in combination with lenalidomide and rituximab, what we call R-squared. You can see that these patients had CD20 positive relapse or refractory follicular lymphoma. This could be after 1 line of prior therapy for those patients. They had to have measurable disease that required treatment. Epcoritamab was given at a dose of 48 milligrams. This was given sub-Q. After that ramp-up phase for patients, they would go on to receive epcoritamab weekly for the first 2 cycles, every other week for a few cycles, and then starting with cycle 6, patients would receive epcoritamab every 4 weeks for up to 2 years of therapy. R-squared was given in the typical fashion with rituximab as well as lenalidomide, continuing for up to 5 cycles with the rituximab and lenalidomide. The primary endpoint was overall response rate, with secondary endpoints including duration of response, progression-free survival, and time to next treatment. In looking at the response rate, a total of 79 patients were evaluated. 96% of patients met the primary endpoint of overall response. 83% of patients met the criteria for a complete metabolic response, and about 13% of patients met the criteria for a partial metabolic response. After a median follow-up of 5.6 months, the median duration of response has not yet been reached. And looking at some of the safety data, you can see that most of the toxicity seen with epcoritamab is grade 1 or 2. This includes injection site reactions. CRS was seen in patients at 43%. But again, most of that was grade 1 or 2, only 7% experienced grade 3 or higher CRS. We also see some GI toxicities with constipation and diarrhea. We can also see neutropenia and fatigue in those patients. Looking at specifically at that cytokine release syndrome, as I mentioned, the majority of this was grade 1 or 2. The median time to CRS resolution was approximately 4 days. Only one patient discontinued therapy due to cytokine release syndrome, and a total of 3 patients required TOCI. I'll now switch gears and talk about a small molecule inhibitor that potentially could be an option for patients with follicular lymphoma. Zanubrutinib is an oral Bruton's tyrosine kinase inhibitor, or a BTK inhibitor, that's currently FDA approved for the treatment of patients with relapse refractory mantle cell lymphoma, for CLL, as well as Waldenstrom's macroglobulinemia. But there is some data out there that supports the use of zanubrutinib in other B-cell malignancies. Data was presented from the Rosewood study at ASH last year that looked at zanubrutinib in the treatment of patients with relapse or refractory follicular lymphoma. You can see the patient population here. Patients had grade 1 to 3A follicular lymphoma. They had to be previously treated with at least 2 lines of prior therapy, including an anti-CD20 monoclonal antibody and an alkylating agent. Patients were not allowed to have received prior BTK therapy. Patients were randomized in a 2-to-1 fashion to receive either zanubrutinib plus obinutuzumab or obinutuzumab as a single agent. You can see that obinutuzumab was given in our standard dosing, and patients could receive up to 20 doses of obinutuzumab. The zanubrutinib was continued until disease progression or unacceptable toxicity. The primary endpoint of the Rosewood study was overall response rate. In looking at the response rate, we can see a total of 145 patients received zanubrutinib plus obinutuzumab versus 72 patients in the OB arm single agent. Overall response rate in the combination arm was 68% versus 45% in the obinutuzumab arm. As we look at the depth of that response, you can see that 37% of patients experienced a complete response, 31% of patients experienced a partial response. In looking at the PFS, we see a PFS advantage in that combination arm, 27.4 months versus 11.2 months in the obinutuzumab arm. And in looking at median time to next treatment, that has not yet been reached in the combination arm versus 12.1 months in the obinutuzumab arm. In looking at safety in the combination arm, you can see that the adverse events were pretty similar in both groups. Thrombocytopenia was higher in the combination group with zanubrutinib and obinutuzumab at 34% versus 23%. Again, the majority of that was grade 1 or 2. We can also see some other toxicities, including myelosuppression, such as neutropenia, again, GI toxicities, such as diarrhea and constipation. When we talk specifically about Bruton's tyrosine kinase inhibitors, we often look at some adverse events of special interest. When we look at those and compare those with the obinutuzumab as single agent, we do see a higher incidence of hemorrhage in the combination group of 26.6% versus 8.5%. Though this combination is not yet FDA approved, I do think that this will soon be an option for our patients with relapsed or refractory follicular lymphoma. And that is what I have. I'll take any questions or comments.
Any questions for Dr. Champion? I have a quick one. There's been some literature recently about T-cell depletion.
Yes.
And how, if you just kind of think forward, how do you think we're going to be using bispecific antibodies in the future?
I would ask Dr. Stevens how we're going to use bispecific antibodies in the future. No, I mean, there is, so as we talk about these bispecific antibodies and we talk about this, you know, there is a certain level of that T-cell depletion, and we see that a lot more when we talk about our therapies in myeloma that are weekly continuously, and those patients won't be able to mount that response that we're looking for. So I do see that there may be some dose modifications in these, kind of building in a rest period, if you will, for these patients to allow for that T-cell repletion for those patients.
Thanks again. And now we will continue with Dr. Basil Altus giving us radiation updates. He completed his medical education at the University of Colorado in Denver, found a passion for oncology, and did his residency at Loyola University Medical Center and then was on the clinical faculty at the University of Illinois and affiliated faculty at Loyola University Medical Center. He's given multiple oral presentations at prominent radiation oncology conferences throughout the country and published his research in several noteworthy journals. He is now a part of Norton Cancer Institute. He's a frequent participant in our weekly hematologic malignancy tumor board, and we always appreciate his input. Please welcome.
Thank you for that introduction. So yes, my name is Bassel Altus. I'm a radiation oncologist at Norton Cancer Institute. And my presentation today is on radiation oncology updates within lymphoma. So I'm trying to figure out, is it just here? Okay, so I don't have any disclosures. So a little brief history. Radiation therapy actually was the main mode of treatment, as many of us know, for lymphoma. It was pretty effective, but given the extended field and high dose levels we had to use in the past, it was associated with significant late toxicity and even mortality. So thankfully, then came a more effective and less toxic chemotherapy, along with other modalities that we heard a lot about today. And so what is the question lies as what is the role of radiation therapy now? Especially with some of the newer ways we're able to treat some of the smaller fields and lower radiation doses. So in order to do this, I'm going to try to go quite quickly, given the breadth of the subjects I'm going to cover. And I'm going to be discussing the role of radiation therapy in Hodgkin lymphoma, early stage, favorable and unfavorable, along with advanced, and then focusing on non-Hodgkin lymphoma, indolent and advanced as well. So moving on to Hodgkin lymphoma, early stage favorable disease. I'm just going to highlight some of the most recent studies as long as the more impactful studies. So there were three recent publications, German Hodgkin study group, HD16, along with ERTC, H10. They had a favorable and unfavorable. The unfavorable I'll be presenting on the next slide, the results of that. And then there was also the RAPID trial. And what this trial attempted to do was emit radiation therapy in early stage favorable Hodgkin's lymphoma. And so what they tried was two to three cycles of ABVD, and the patients who were PET negative on interim PET, they either did not receive radiation therapy or they received radiation therapy. And what all these trials demonstrated was an improvement in progression-free survival with radiation, 93 to 99%, and 87 to 90% without. So what we found out was that the emission of radiation therapy leads to worse progression-free survival, about 5%, and that acute grade 3 toxicity was very low, around 3%. That said, outcomes are still very good without radiation therapy. As you can see, 87 to 90% without it. And then although acute grade 3 toxicity was very low and mild, the long-term complications are still yet to be seen with these smaller fields and lower doses. So I think for early stage, these patients, I think it still warrants an evaluation by a radiation oncologist to discuss risk and benefits. For early stage unfavorable Hodgkin's lymphoma, there is the H10 unfavorable portion of the H10 study, along with the German Hodgkin study group HD17 in a recently phase 2 trial. The H10 unfavorable demonstrated that there still was a progression-free survival benefit with radiation therapy in interim PET negative patients. However, the HD17 study noted that if you use dose-escalated BIACOP, these patients had no improvement with the addition of radiation therapy. Those without a complete response still received radiation. And then the phase 2 trial that was published a couple months ago, 3 or 4 months ago, it's an interesting trial that emitted bleomycin and included nivolumab in the typical chemotherapy regimen for Hodgkin's lymphoma. And what they found was, importantly from a radiation perspective, is that all of these patients received radiation therapy, 30 gray, and involved site radiation. And what they found was that after 41 months, 100% of patients were alive, and about 100% of the patients had a progression-free survival benefit. Had no evidence of disease progression. And so they comment that there is outstanding efficacy and relatively favorable safety profile with this therapeutic approach, which is basically omission of bleomycin, inclusion of nivolumab, and radiation therapy was required. For advanced Hodgkin's lymphoma, there was a RATHL trial that evaluates stage 2 bulky disease along with stage 3 and 4 disease. They attempted to de-escalate the use of bleomycin after interim PET, and they also discouraged the use of radiation therapy. And those patients who had negative PET-CT and negative interim PET-CT results, they favored very well without the addition of bleomycin or radiation. So it seems like in that patient population, both bleomycin and radiation could be omitted. For those with a positive PET, they did transition to escalated therapy with BIACOP, and they also those patients also received radiation, and they described that as being an effective consolidative therapy in those with PET-positive disease. There's 2 other studies from the German Hodgkin study group, HD15 and HD18, that also de-escalated the use of a number of BIACOP cycles after interim PET-CT. Overall, the results favored a de-escalation. In terms of the use of radiation therapy, they relegated it to patients who had residual disease with 2.5 centimeters or greater, and they also had to be PET positive. It's important to note that in those patients that did have residual disease and received radiation therapy, their outcomes were similar to those who achieved a complete response after PET negative therapy and de-escalation. So to quickly summarize, for favorable patients, there is a progression-free survival benefit even with PET-negative disease, low acute toxicity. However, overall outcomes are still good without radiation. For patients who are unfavorable, there was no incremental benefit for radiation therapy with PET-negative disease and the use of escalated BIACOP. And then there was also, though, an interesting trial with the use of nivolumab instead of bleomycin that showed great results with low toxicity. We'll still have to await phase 3 validation of that. And then for advanced Hodgkin lymphoma, it's really relegated to those patients who have residual disease, but outcomes are still very good, or relatively good, if radiation is used appropriately. So for moving on to non-Hodgkin's lymphoma, so for indolent non-Hodgkin's lymphoma, for those who have stage 1 or contiguous stage 2 disease, the NCCN standard is still radiation therapy. And in an attempt to reduce the risk of side effects in these patients, given that their outcomes are relatively good, although, as we heard in our previous talk, they're considered non-curable in many ways. But nonetheless, there has been a recent publication, at least long-term results of a publication that used 24 gray versus 4 graves, named the FORT trial. And they tried to evaluate de-escalation of radiation therapy and evaluating the local control in these patients. And not surprisingly, the 5-year progression-free survival locally was worse with the 4 gray versus the 24 gray, 90% versus 70%. But I would argue that using 4 gray, which is a very, very safe radiation dose, and still getting 70% progression-free survival after 5 years is pretty good. And in addition to the fact that you can always consolidate with 20 or 24 gray in the future. And so I think it's a good therapy for those who just want palliation or those who logistically have difficulties coming back and forth for treatment or worried about side effects. That said, there are certain subsites. There was a recent publication that tried 4 gray and 2 fractions for certain subsites, for orbital lymphoma specifically, to evaluate the local control benefit there or the outcomes there. And they found that after a follow-up of 28 months, it was published, it was a group from MD Anderson, that there was a 95% local control with the use of 4 gray and 2 fractions. And then the patient who did progress, or the patients that did progress, received 20 gray consolidated therapy and had a complete response. Moving on to non-bulky favorable non-Hodgkin's lymphoma. So historically, bulky disease was treated with radiation therapy. So the question is, those with non-bulky disease, should we be treating them with radiation? And there was the LISA trial, as well as the FLYER trial. And long story short, those with IPI 0 who had a PET-negative disease after interim PET, after 4 cycles of R-CHOP, really did not require any further radiation therapy. They did very well without further radiation. Those with IPI 1, the argument is that they still need either R-CHOP times 6 or R-CHOP times 3 plus radiation. And that was seen both in the LISA trial and the FLYER trial. How about those patients with bulky disease or aggressive non-Hodgkin's lymphoma? I'm just going to be focusing on a subset of patients, those who are elderly. There was a Recovery 60 trial this was a per protocol analysis of a sub-analysis of the use of radiation therapy in the group that had the best arm in the Recovery 60. And what they found was that if the patients had bulky disease or extralymphatic disease and received radiation of 36 gray involved site, that they had event-free survival, progression-free survival, and overall survival benefit with radiation. However, for the optimal 60, which is currently published in abstract form, they used a PET adaptive approach, which Recover 60 didn't. And those patients who had an interim PET negative disease, the use of radiation therapy did not improve outcomes. So there was an ability to reduce the rate of radiation about 42% because of those patients who had PET negative disease. And it's important to note, though, that patients who had PET positive disease who did not receive radiation therapy had significantly inferior progression-free survival than those patients who did have radiation and were PET positive. So the next two slides are kind of more hypothesis generating. There's not much data in regards to the use of radiation therapy in the autologous transplant setting or the CAR T setting in the relapsed refractory non-Hodgkin lymphoma patients. But it's a kind of hypothesis generating, or I guess more of a reasonable approach, given that at least in the autologous transplant setting, most of the patients recur at the sites of known disease after relapse. So nearly 80% of the patients who relapse following autologous transplant failed in pre-transplant sites. And then those patients who had a PET negative or near PET complete response before transplant usually fare better afterwards. So the idea is that if we can treat these lesions locally with radiation, get patients to near to or complete response, maybe they'll fare better. And there was a retrospective series by Yang et al. That did demonstrate improved progression-free survival and disease-specific survival in this setting. With radiation therapy, 31% failed post-transplant, but all those patients out of the radiation field. Without radiation, there was 60% failed, and they all failed locally. And then those who don't respond well, don't have a complete response after systemic therapy, was noted to have an improvement, relatively speaking, to historical controls with the addition of radiation. Again, with relapsed refractory disease for CAR T therapy, the thought process here is twofold, or threefold actually. One is that a decent number of these patients fail locally, just like in an autologous stem cell transplant patients. And then the other theory or thought here is that it does take a while to prepare these CAR T cells, and so radiation therapy can work as a bridge until these therapies can be infused into our patients. And so there was a publication, I believe this was out of MD Anderson as well, that treated patients who had less than 5 active disease sites, and noted that, and compared those who didn't receive treatment, and noted an improvement in progression-free survival and overall survival. Again, this is retrospective and hypothesis generating here. The other thought is that with CAR T cell therapy, there's high risk of severe cytokine release syndrome and neurologic toxicity. And if we can reduce the overall tumor burden with radiation therapy, we can prevent those significant toxicities related to CAR T cell. This was a phase 2 trial out of Asia that demonstrated the use of radiation therapy did indeed reduce the risk of cytokine release syndrome and neurotoxicity. So just to summarize for the non-Hodgkin lymphoma, for indolent non-Hodgkin lymphoma, especially with those stage 1 and stage 2, the standard of care is still low-dose radiation therapy, and some patients can get very low doses of radiation, and those who have orbital disease. For non-bulky stage 1 to 2 non-Hodgkin's lymphoma, the treatment paradigm is either R-CHOP times 4 for those IPI 0 and PET negative disease, or R-CHOP times 6, plus or minus radiation. Pretty much the same thing with bulky advanced disease, R-CHOP times 6 plus or minus radiation. And those with elderly patients who have difficulties getting back and forth or can't tolerate full course of chemotherapy, it's reasonable to do R-CHOP times 3 and radiation after that. So that's all I have. I appreciate everyone's attention here, and if anyone has any questions. over there, Dr. Malley.
My question is, or thanks for that presentation. My question is for the pre-CAR T data with the use of radiation to debulk the tumor. That trial, did that was a conceptual reduction in CRS risk, or the data actually supported that? That's a very interesting idea to reduce the risk associated with toxicity with those therapies.
Yeah, sorry, I missed the question.
Oh, so can you talk a little bit more about that study that utilized radiation prior to CAR T therapy to reduce the risk of cytokine release syndrome?
Yeah, so it was basically in patients with significant disease or bulky disease, but also in patients who had limited sites of disease where radiation therapy made sense. They treated patients who had primarily, they focused their radiation therapy on the largest tumor burden in hopes that the reduction will lead to improvement in toxicity outcomes.
But it was sort of historical controls, probably not a randomized.
It was not randomized. No, it was a phase 2 non-randomized.
And what was the dose of radiation?
30 gray.
Okay.
Yeah.
Over how many fractions?
15.
Okay. So that's a 2-week while you're waiting for the cells to be
Basically,
processed.
yeah, 2 to 3 weeks. Yeah.
Well, thank you again. It's very
Of course. All right, thank you guys.
Our penultimate speaker today is the amazing Dr. Jay Jung. She graduated downriver at the Washington University School of Medicine in St. Louis with a medical degree and a PhD. She's also completed her internship and residency in dermatology from the Washington University as well. This led to a faculty position in dermatology at the City of Hope Comprehensive Cancer Center in Duarte, California. We are very fortunate to have her join us in 2016, where she serves as the Director of Oncodermatology for the Norton Cancer Institute. She has an extensive background in oncodermatology. She has published and presented on a wide array of topics related to dermatological manifestations associated with bone marrow and breast cancer. Depending on your perspective, Dr. Jung's talks have always had the best or worst photographs, but we always look forward to what she has to say. Without further ado, Dr. Jung, thank you.
Thank you for inviting me to speak again and putting me after lunch instead of before. I don't think there's too many hideous ones today. These are all of my past and current disclosures. None of them are relevant for the talk today. I will be discussing off-label use of medications because cutaneous lymphomas, unfortunately, just don't have a lot of great FDA-approved randomized controlled trial diseases. Here we go. So cutaneous lymphomas are this rare, heterogeneous group of extranodal T-cell lymphomas, really characterized primarily by skin involvement. Mycosis fungoides is the most common subtype, and we will spend most of the time talking about this subset. Sézary syndrome is a distinct variant that presents with erythroderma and often with leukemic involvement. And there's a rising annual incidence in the US, and certainly we have seen our fair share of cutaneous lymphomas here at Norton. Here's a diagram of the types of involvement that we see, and I'll give you some real-life pictures in just a moment here. The prognosis for cutaneous lymphomas is really dependent on how much of the skin is involved. T1, which is considered less than 10% of your body surface area, whether it's patch or plaque, does make some difference. And a T2 is considered greater than 10% body surface area. T3 would include one or more tumors, and tumors are more bulky, and I'll show you some examples. T4 is the erythrodermic variant, where they're just red all over. And as you can see, these T categories really do separate themselves out, with T1s doing very well and the T3 and 4s doing very poorly. So here's sorry, my allergies are terrible. Louisville is trying to kill me with its pollen. So this is a patch, flat. It does not have any induration. When you kind of put your hand over it, it should be flat with the skin. It does often have scale. These are plaques. These are going to be more elevated. It's going to feel real firm, and it will be elevated above the surrounding skin. Here's an example of the tumor. This is obviously a tumor to anybody who looks at it, but it is any nodular lesion that is over 1 centimeter. And it also has, as you can imagine, this would evidence of infiltration deeply into the subcutis. Thank you. Here is an example of erythroderma. This patient came in. We call it skin snow in our clinic, where they take off their clothes so that they can, show us their skin. And it's literally skin shedding snow all over the floor. And these people are quite unhappy, as you would imagine. Once you get past the skin involvement and into systemic involvement, patients do much, much more poorly. Here is a brief staging system. It also includes the lymph nodes, as most TNM staging does, as well as blood. The blood involvement is considered, kind of a low versus high burden. The high burden does affect prognosis, whereas the low burden is significant but doesn't affect prognosis. And as you can see here, if you have extracutaneous disease in yellow, circled, it drops your prognosis pretty dismally, and these patients often do not do very well. The current clinical management of cutaneous lymphoma is really based on overlapping types of skin-directed treatments. As with most of these lymphomas, it is very symptom-directed, and we always want to make sure that the treatment is not worse than the disease. So certainly, if somebody comes in with cutaneous lymphoma, you could give them chemotherapy. You could give them a lot of different things that would help manage their disease. But it is not considered curable, so we like to try to save kind of the bigger gun treatments for later on in their course and start kind of easy on them. Because a lot of times, even though it is distressing to them to have, it is often not very symptomatic when it is mild and very low burden. One of the other problems with cutaneous lymphoma is that it's just very, very challenging to diagnose. There is not a pregnancy test for this disease. You cannot just kind of come in and say, this is cutaneous lymphoma. Even when you biopsy it multiple times, you don't really find the smoking gun in that biopsy. And so I have a lot of patients who come in, like this gal who now is seeing Dr. Malley, who have not been diagnosed appropriately in many, many years. So in her case, she had a rash for over 20 years. And when it started, it looked like psoriasis, so it was treated like psoriasis. It responded partially, always, to some sort of topical. And so it took her 20 years and really extensive progression before she had an appropriate diagnosis and then appropriate treatment. Again, here's another patient. For about 4 years, he's had this rash. He was patch tested extensively, was told that it was allergic contact dermatitis. And as you can see, it's kind of in his waist area, so they thought it was his detergent, his clothes, elastics, etc. So when I see a patient like this, I always like to do 2 different types of biopsies. A punch biopsy is standard from dermatologists, but it really only gives you 4 millimeters of that dermal epidermal junction, and if there's any pathologists in the audience, you know that you need that DE to make the diagnosis. So I always do a second broad shave. It does help aid diagnosis, and hopefully we can get a lot of these patients diagnosed more rapidly. So because there aren't really any great new treatments, I'm going to focus my talk on cases that have come through that really kind of delineate how this disease is treated. This first gal was from pretty far away, and her medical oncologist in the community wanted to put her on chemotherapy. As you can see, She has a high disease burden. She's very miserable. She generated a lot of skin snow. And she wanted to see if there was something that she could do besides chemotherapy. So, I have these out of order. Oh, here she is. Sorry. So here we first start with a topical steroid, and then we added low-dose methotrexate. I typically don't go over 15, 20 milligrams. So the skin snow part got better, but she's still quite red. Now I'm gonna have to go back to where it was. Okay, so because she lives so far away, one of the things that we like to use for cutaneous lymphoma is narrowband. It is a very specific wavelength of light, but because she couldn't get to any place that had it, I just had her sit outside for about 10, 15 minutes a day, and she did great. She actually stayed in remission until she passed away from other causes. So here's the other side of the diagnosis is that, sorry guys. So this is a patient who's had a rash, and she got a biopsy, so everything was done appropriately. But then, all of a sudden she's, a 30-something-year-old woman, and she's like, they told me I have cancer. Is this really cancer? And yes, it can be very, very subtle. It can just look like these red patches. And these are the cases where I do like to use primarily topical steroid and narrowband. This is what the box actually looks like. It's kind of like a stand-up tanning bed. And she also was able to use a topical nitrogen mustard on some stubborn patches. And ultimately, she has been in remission now, I think for 3 or 4 years, even without the light. So oftentimes when it is subtle in appearance, it can go into a prolonged remission. And narrowband is one of the workhorses of this type of kind of low burden disease. Oh, here we go. And here is another interesting case. This is, I think he was about 13 when he first came in, biopsy done in Cincinnati, and it was a CD30 positive atypical lymphocytic infiltrate. He was told that he had lymphoma, and they were going to, kind of proceed with pretty aggressive treatment. And this is actually lymphomatoid papulosis. It is on that spectrum of atypical CD30 positive, lymphocytic proliferations that are histologically really look like cutaneous lymphoma, but these are considered benign. It is rare. They come up in crops. They are self-healing. There isn't really a cure, but these do tend to remit with time on their own. And because of this kind of underlying association with some form of lymphoma, we do follow them just to make sure that nothing, kind of presents itself later in life. And this patient did fine with a little bit of topical steroid and some light treatments. And he actually has not had any recurrences in about 2 years. Here's another case in an older adult. These are really distressing to have, but they're typically asymptomatic. And he had a complete remission just with topical steroid alone. Here's another case, again, a pediatric cutaneous lymphoma. This was definitely a delayed diagnosis. Oftentimes, especially in children, you can get bald patches with, what we call tinea incognito or fungal infections that aren't very obvious. And so he was treated with antifungals for, I think, 3 or 4 years before he really progressed and it became obvious that it was not just a fungal infection. And he came to see me. This was his PET scan, and you can see there's some low-level nodal involvement. We first started with radiation to the bulky lesions. He then received brentuximab for 4 cycles. He developed some new lesions on his legs. We started him on isotretinoin for about, I think it was like 3 to 6 months to see if that would put him in some sort of remission, and it did not. But then we put him on methotrexate, and he's had, really stable kind of low-level disease for about 5 years now. This is one of my favorite patients. When he came in, he was definitely kind of top 10 skin snow patient, and he was very miserable. He had to wear a thermal jacket that had a battery pack because he was so cold. You can see he could barely walk because the plantar feet were affected. And, he had tried many treatments, and he was just kind of very frustrated, didn't know where else to proceed. He ended up going back home. I believe he had a home in Tennessee, and they gave him weekly gemcitabine, which, as you can see, was poorly tolerated. He was bleeding from nearly every place on his skin. He did, I think, feel a little bit better, but obviously this was not going to be something that he could continue or sustain. So this is where one of my favorite treatments come in. This is total skin electron beam, and I think the radiation oncologists can attest to this. It is very well tolerated. They do lose, their hair, their nails, but it often, grows back. They can get odd pigmentation, which he did, but it will often put these patients into really a prolonged remission, which is great. And in fact, after I did the total skin electron beam, he left back to his houseboat, and I hadn't heard from him in so long. I actually thought that the patient had died. And when I saw his wife in the waiting room with this other guy, I thought that she had maybe gotten remarried, but here he is. He came back from whatever his houseboat was, and he had grown hair, his skin looked normal, and he had been doing great, and he's still, back on his houseboat today, has not had to have any additional treatment, as far as I know. So this is, so those were all cutaneous T-cell lymphomas. This is my last case, and this is really exciting, actually, for me. This is primary cutaneous B-cell lymphoma, and these are always very frustrating because I have done Kenalog in the past, but it's like playing whack-a-mole because they just keep coming back in the same place or a different place. And primary cutaneous B-cell lymphomas are about 25% of the cutaneous lymphomas, and the T-cell variants are about 75%. This arises from the skin without evidence of extracutaneous disease at the time of diagnosis. So this typically has a really excellent prognosis, but then there's one type that has a bad prognosis, but then the question is what to do with it. It has a great prognosis, and you don't want the treatment to be worse than the disease, but then what do you do? So we looked around for a treatment, and this patient actually came to me with this. There are many case reports, particularly in Europe. Germany specifically has a lot of these cases where they are putting rituximab directly into the lesions, and according to reports, very well tolerated, no side effects or complications. So we went ahead and got started, and here he is. We did 9 injections of rituximab. We gave him, at certain visits, we gave him also some intralesional steroid because of the inflammation and the pain at the areas. And he has had a, kind of a sustained clinical response ever since then. And he is very happy that he has not had any more surgeries. I think he had had 10 by the time he had come to see me because they had been, routinely excised by ENT. And they were running out of places to excise and wanted to do radiation, but as you know, you can only do radiation so many times, so he was worried what happens if it comes back after the radiation. So he's doing great, and he's very happy, and so am I. Thank you very much. This is us. The red arrow is me cowering in the front.
Any questions for Dr. Jung? Dr. Hadley?
I think all of us have had patients who are delayed in their diagnosis because they get biopsied and it's eczema, and years going on and on and on. So my question is kind of a big general one. With all the information we have about molecular stuff these days. Are there no molecular tools or gene expression profiles
So
that can differentiate?
they're all in clinical trials or, in investigative areas. My suspicion is that they are proprietary and everybody's kind of racing to get their profile like approved so that they can, profit from it, because it has not come through kind of academic channels. I know that there are studies, though, of gene arrays that, have pretty good confidence intervals that show eczema versus cutaneous lymphoma. So I think that that's still coming.
Oh, just another general question. I've always been impressed that we do a pretty good job of killing B cells, with drugs that damage the DNA. They go through apoptosis almost like they want to. But T cells are so hard to kill. Do we know why? I mean, what's different about a T cell compared to a B cell that they're so refractory to? Even T cell lymphomas, diffuse large lymphomas are T cells.
I'm not sure I have the best answer to that, but my understanding, my rudimentary understanding, is that B cells are more alike, whereas T cells are super varied. So, you can try to wipe out a T cell, but then you'll have the ones that hide out in the skin, or you'll have the ones that hide out in the lymph node, or I think they all have different zip codes, and you have to target all of them with your, mailing list instead of like just sending them to one place.
T cell, a CAR T that recognizes another T?
That recognizes what, I'm sorry?
A CAR T that would recognize another T? Is there?
Yes, we do. We're getting ready to open a trial of cellular therapy for T-cell disease, yes.
Thank you.
It's a little bit tricky because you need to make sure that it's not attacking itself.
Right.
So you do that by removing the T-cell receptor. Anyway, well, that's a
It's
topic for
interesting.
another
Thank you.
day.
Thank you, guys.
Thank you very much. We're going to conclude today's program with a presentation on diffuse large B-cell lymphoma by Dr. Joe Malley. He's a former part-time musician, now full-time Girl Scout cookie salesman in our office, and a medical oncologist with the Norton Cancer Institute. He has a special interest in hematologic and urologic malignancies, for which he is a principal investigator on a number of clinical trials. He earned his medical degree at Temple University in Philadelphia, completed his residency in internal medicine and fellowship at The Ohio State University in Columbus, Ohio. Again, he has a special interest in clinical trials and management. He's board certified in medical oncology and internal medicine. Welcome, Dr. Malley.
Thanks, Don. Hello again, everybody. Thank you for sticking around. I'll try to be succinct with my slides here today. So I've been tasked with communicating information, updates from ASH 22, and then also just some relevant data from conversations that have been swirling about management of patients with these types of diseases. So these are the more aggressive subtypes of lymphoma. I think, it's pretty much impossible to be working in this space right now and not hearing dramatic stories about patients that are undergoing therapy with CAR T. So the bulk majority of my conversation will be about utilizing CAR T therapies, and it's not that the non-CAR T novel therapeutics that are being developed right now for aggressive non-Hodgkin's lymphoma aren't useful. It's just time constraints and trying to familiarize everybody with the information that's being talked about. So I have no disclosures to communicate. So I'm sure most of us have seen schematics like this quite a few times, but just to orient you, so there's two cartoons there. On the top left, there's a schematic of the action step of the cell therapy product at the tumor site, and then at the tumor cell, and then on the right there is a schematic of the patient experience for autologous CAR T therapy, where the cells are leukapheresed and then sent to company for production and then eventually infused back. A couple things I wanted to mention about these things. So multiple new approvals for these types of therapies. You see the list of 3 different products that are currently FDA approved. All CAR T therapies that are FDA approved currently are directed at a cell surface molecule called CD19. That's changing, especially with some of the products that are in the pipeline, but for right now, all of them are directed toward that. Up until most recently, patients had to have relapsed refractory diffuse large B-cell after 2 lines of therapy. And I'll mention one product was given approval for patients in the 2nd line. There are some caveats to that as to when you can get FDA insurance approval for these therapies, but by and large, that's the case. One thing that Dr. Altus was bringing up, and I think is a relevant consideration, people don't talk about as much, not yet anyway, is the optimal bridging therapy for patients for CAR T. So typically, these diseases are relatively aggressive, and so you have to, because of the timeline that exists to get patients to the point where they can actually get the therapy, you have to utilize strategies to kind of just bridge them. And some of the non-CAR T therapeutics, I'm interested to see over the course of the next couple of years how those therapies are intertwined into bridging patients to maybe some more definitive therapies such as CAR T in place of the historical standard platinum-based chemotherapy or some other chemotherapy agents that have been around for a few decades. And by and large, I also wanted to mention that all the products that are currently FDA approved generally produce remissions in around 30% of patients, for durable remissions. So that's what I wanted to communicate about the general concepts for this. So this is a study that was presented at ASH 22. It's called the Transform study, and utilizing a CAR product called Breyanzi. You can see the dramatic difference in their primary endpoint there, 17.5 months versus 2.5 months for standard of care therapy, and this resulted in the moving forward of the FDA approval for this product for these patients. The interesting thing there, and this is always the case with modern clinical trial designs for novel therapeutics, the overall survival was not the primary endpoint, and overall survival was very difficult to tease out because there was crossover that was permitted in this study. They did try to do some remarkable statistical juggling, and when controlling for those things, there's a suggestion that there's an overall survival benefit. I suspect that there is, but until we have that statistical confirmation, it's hard to kind of to rely on that. Availability for these products, the three different options is challenging, and so the next study that I wanted to bring up here, this was also presented at ASH 22, is an effort to communicate some of the differences between the products. Now this is a retrospective review, so you have to take that with a grain of salt, I guess, but it's more thought-provoking. So what this retrospective review revealed was that the Lysocell product had a reduced risk of some of the unique toxicities associated with these cell therapy products, but the efficacy rates were relatively similar. As somebody that manages patients with these types of diseases, I think this information is not yet relevant to decision-making, although it's thought-provoking, again, not yet ready to impact decision-making because the availability is still a primary concern when trying to pursue these types of therapies. And then in addition to that, the ultimate goal with any of these advanced cell therapy products is the efficacy rate is what you're really, really shooting for. Certainly, again, for somebody now that has managed quite a few patients getting these types of therapies, cytokine release syndrome, the neurologic toxicities, although they can sound scary and they can imagine feel scary, they're manageable problems now. So we have pretty good understanding of how to manage that.
The other thing that I wanted to mention, actually, I'll mention that in a minute. So, as I was alluding to, challenges associated with these products is access. The patients have aggressive disease histology, and so sometimes patients don't have time to sit around and wait 21, 27 days from pheresis to infusion. And so there are lots and lots of efforts now that the proof of concept has been around for years of trying to reduce the steps that patients have to experience to get these cells infused. This is something that was presented at ASH, I think is pretty interesting. It's a Novartis product, I think, called Rapicell. And what the design of this is so when the cells get to the company, they have to genetically engineer them to be cancer fighting. And then after that, the cells have to be grown or replicated to a volume that is considered a successful volume at eliminating cancer. And that replication process can take a while. And so this study was a proof of concept phase 1 study that instead of having that replication process take place in a lab, the cell therapy product is given in conjunction with a proprietary adjunct called a T-charge, and that replication process actually takes place in vivo as opposed to in vitro. So reducing, you see there, the manufacturing timeline to just 2 days. So you can see the response rates there are pretty desirable. And I think this is interesting when you're looking at modifying something that's already considered an effective strategy, so that I think it's called a spider plot. I forget all the different names of the different graphs, but the first graph there on the left, this is a measurement of the cell therapy product's DNA in patients at various different cell therapy dose levels. And so you can see there, despite dose level number 2 at 12 times 10 to the 6th cells, the PCR levels were more or less the same as those at higher dose levels. So that's important. And then in addition to that, when you're modifying these cells in vivo, it's harder to control for the balance of the various types of T cells that we were just hearing about. And that's considered important to maintain the toxicity profile, is to have the balance of the T cells in the subsequent cell therapy product. And as you can see there, as measured in vivo, the profile of the balance between CD4 and CD8 cells maintained after infusion. So pretty impressive information there. I think you'll start hearing a lot more about these types of strategies to reduce the barriers to getting patients access to them. I also found that, as thinking about this, this is a phase 1 study, and for years now, we've been hearing about comparison of CAR T to standard of care, which has always been platinum-based chemotherapy and a consolidative autologous stem cell transplant. So it's interesting to think that now if this type of thing, this study or some other, gets to the point where they're ready to take it to market, comparison is going to have to be against standard of care CAR T as opposed to salvage chemotherapy, which has been the historical standard for how many decades now. Anyway, so that's that. This is another this is another trial that was that actually Dr. Stevens led at the NCI and contributed a number of patients with the help of our research team. Actually was presented at ASH 21. And instead of autologous stem cell infusion, this is what's called allogeneic CAR T. I think I said stem cell. Sorry. Allogeneic CAR T. And for this, the reason that this is so useful is that you can have non-cancer patients donate their T cells. Those cells are genetically engineered and then just be hanging out on a shelf, kind of like a medicine that you would order from the pharmacy for patients, and be available when needed. So you can see some of the data that's presented there. I think at the time, there was some significant concern that when utilizing allogeneic CAR T cell therapy, that there would be a concern for something like graft versus host disease, or potentially even host versus product destruction. That wasn't revealed in this phase 1 study, and no patients experienced any kind of DLT relating to graft versus host disease. So I think this is the kind of thing that you'll see, coming down the line now that there are so many products that are commercially available by way of CAR T. One other thing I wanted to mention, so in the prior study, sadly, the patients that were enrolled in that, despite the timeline being reduced for production to 2 days, the vein-to-vein time was actually the same as what is currently commercially available. So just, again, elucidating that the various logistical steps are just as important as controlling access. This study was actually pretty impressive. From time of enrollment to infusion of the cell therapy, the median time for that was 5 days. So again, proving that if you can utilize some of these off-the-shelf products, you could potentially spare patients a lot of toxicity from the bridging therapies, and certainly capture a few more patients that would otherwise probably succumb to their disease. I did mention again at the beginning, there's quite a few novel therapeutic options that are not CAR T, and people are talking about those medicines just as much as the CAR T. But again, the nature of this was really just to kind of highlight some of the things that folks are talking about right now. But again, I did want to highlight the fact that you see the recently FDA-approved options there, and then some of these bispecific antibodies that are currently in various stages of development. I think sequencing of these therapies, both with CAR T and the novel therapeutics, is really going to be where the money's at in the next few years, because these therapies can actually work together. But the things to think about really are the toxicity profile, the cytokine release syndrome, and the neurologic toxicities that we've heard multiple people talk about today. And then in addition to that, the targets are very specific, which is great because it's precision medicine. But you can imagine that if you're exposing patients to CD19 directed therapy multiple times, that eventually that CD19 marker will disappear. And so what is the efficacy of some of these targeted therapies in the absence of the target? That's going to be an interesting thing to pay attention to. We've seen that historically with rituximab and the CD20 molecule as well. But I imagine that these therapies will work together, is kind of the idea. I have 2 more slides to highlight. Again, with regard to the CAR T cell therapy, so CNS lymphoma is kind of a aggressive lymphoma that doesn't get thought of too often because it's pretty rare, or I should say primary CNS lymphoma. But one of the things about it is that there's so few treatment options that work. And so for a long time, folks have been hopeful that these more novel interventions will be useful for patients with CNS lymphoma. So this was another study that was presented at ASH 22, again, a proof of concept study, but was designed based on the fact that patients who had gotten commercially available CAR T therapy infused had DNA of those T cells actually measurable in their cerebrospinal fluid. And so there was hope that that crosses the blood-brain barrier. And then in addition to that, there was observational data that patients who had been given commercially available CAR T therapy and had secondary CNS lymphoma had treatment responses in the brain. And so this study was designed, patients had to have an Ommaya reservoir, which is a direct conduit to, in the skull, to infuse therapy directly into the cerebrospinal fluid, and had the CAR T product directly infused through that. The cell volume was relatively small, as 2 × 10⁶ cell product, and you can see there that 6 out of the 9 patients that were included got a complete remission as a result of it. So this is really an important thing, and I'm hopeful that this will continue to be developed for patients with this really hard to manage disease. I think that's all I had on that. And then this last slide here, I think is just something to pay attention to. Goals of care discussions are always really hard in the work that we do. Finding the right time to talk about those things is a challenging concept. And as these more novel therapeutics, both CAR-T, BiTEs, and all these other really amazing things, antibody-drug conjugates come available, patients are living longer, but sometimes that forces us to re-engage patients over time at each time point of decision-making to say, hey, here are the risks associated with disease. Some of the risks are associated with inpatient hospitalizations and significant toxicities that you might be unaware of. And so this is some data that was published, I think, 3 years ago now, where goals of care conversations that took place prior to 30 days before death or less than 30 days, whether or not they were engaged by their patient's primary oncologist or by an independent provider in the hospital, and then whether or not those conversations happen in the outpatient setting or the inpatient setting for patients with hematologic malignancies. You can see there in the various bar graphs that a lot of those things are things that most of us would consider desirable, whether or not to have a hospital death or not, engaged in hospice greater than 3 days before death or not. Those are things that in my conversations with patients are generally desirable. And so trying to find a way to balance goals of care discussions with patients without extinguishing hope as we continue to offer more and more therapies to older and sicker patients as these new things come online is an important thing, I think, to consider. But with that, we have a number of trials at the NCI that patients with aggressive malignancies can participate in, and here's the list of some of them. And certainly I'd be happy to take any questions on any of the information that I presented here.
Any questions for Dr. Malley? Well, I think you answered all the questions.
Hooray.
Thank you.
Thank you, everybody.